Dear Chairman, dear colleagues, it is a pleasure and an honor for me to be part of this first joint Tigers EUREOS meeting. The organizers gave me the task to discuss with you the maintenance treatment of eosinophilic esophagitis. After a short case presentation, I'll give you some theoretical information regarding the long-term management of EoE. And finally, I'll discuss with you several very practical clinical issues. First, the case presentation, perspective beyond remission. A 25-year-old healthy student presented at our clinics. His personal history was in general unremarkable, except allergies. Since approximately 10 years, he had an allergic rhinitis and an oral allergy syndrome. And since some years, he suffered an intermittent solid food dysphagia. Not more than 2 to 3 events per month. In the last week, somewhat more. This evening, since a dinner with friends in a restaurant, eating a steak, he experienced a complete blockade for solids and liquids. Even saliva was not possible to swallow. 5 hours later, he arrived at our hospital at 1 a.m. in the early morning. The physical examination was unremarkable, and we performed an emergency upper endoscopy. As you can see on this slide, we found the expected food bolus impaction in the mid-esophagus with a lot of saliva. We could successfully remove this bolus, and after disinfection, we found several relevant lesions in the mid-esophagus. From the proximal, non-injured part, we took some biopsies. On this histology, you can see an esophageal squamous epithelium, here the surface, with an eosinophil predominant infiltration with a peak value of 38 eosinophils per high power field. A diagnosis of EoE was made even without the currently not anymore appropriate PPI test. And we discussed with the patient this diagnosis, and we explained him the necessity of a treatment, medical or dietary. According to the patient's desire of treatment with swallow topical corticosteroids, we prescribed fluticasone powder. The patient was discharged, and the control in another 3 months was scheduled. Under treatment with swallow topical corticosteroids, symptoms improved rapidly, and at the date of the control, the patient was completely asymptomatic without any restrictions. The endoscopy under 3 months topical corticosteroids showed a non-inflamed mucosa with some rings, but the passage with a standard endoscope was without any resistance possible. No signs of acute inflammation anymore, and no obvious stricture. Here the histology. You find a non-inflamed esophageal epithelium with a mild basal zone hyperplasia with some papillary elongation and some fibrosis of the lamina propria. The patient was not anymore motivated to use any medication. Respecting his desire, no further treatment was performed and no follow-up visit was scheduled. Act 2. 13 months later, a 26-year-old student was admitted to the emergency station with suspected acute esophageal bolus impaction. He reported that some time ago an EoE was diagnosed, but treated only for a short time. Since several months, he had again difficulties when rapidly swallowing solid food such as steak, sandwich, or dry rice. Again, we scoped the patient and confirmed the clinically suspected food impaction. We could disinfect it, but we found now the mucosa inflamed and some lesions after the several hours intaction duration. And we took biopsies. The esophageal epithelium, can you see here, a relevant eosinophilic infiltration with peak density of 28 eosinophils per high power field. Papillary elongation, marked fibrosis of the lamina propria. Conclusion. In this patient, EoE relapsed despite successful induction treatment. EoE is a progressive disease, develops fibrosis, and even mild symptoms do not prevent esophageal food infections. And finally, patients often disappear when no further controls are arranged. And now we have a long list of questions based on this case. First, is this clinical course typical for EoE? Second, do we have arguments for a long-term management? Which medications have proven and have sustained efficacy over long time periods? Which medications are safe when used over prolonged time periods, and are esophageal food infections preventable? First, rationale for maintenance treatment. What happens with EoE after achieving a clinical histological remission? These are data from the European multi-center trial. All these patients were at the beginning of this 1-year period in clinical and histological remission. These received the treatment, and these patients received only placebo, no active treatment. And as you can see, after a median time of 87 days, the patients were in a relapse. These are data under real-life conditions. Thomas Kreuter from our group performed a cross-sectional analysis of patients coming in a deep remission defined by absolutely free of symptoms for at least 6 months. In endoscopy, no signs of active EoE. Histologically, less than 5 eosinophils. And in these patients, in this condition, we stopped the treatment. And as you can see on this Kaplan-Meier graph, on average of 22.4 weeks, patients experienced a relapse. We can conclude without any treatment, EoE relapses under study and under real-life conditions. Our case that I have presented is therefore absolutely typical for EoE. In this study, Professor Schöpfer from Lausanne addressed the question whether the dangerous, the risky food infections are preventable by a proper treatment or not. And you can see here the percentage, the risk of experience a food impaction, a long-lasting food impaction over 5 years, from 0 to 10%. And here, this part, these patients didn't take any treatment. And the risk is somewhat more than 9% to experience a food impaction with the necessity of an emergency endoscopy within 5 years. On the other side of the graph, you see the very adherent patients. They took more than 75% of the prescribed doses, and their risk is somewhat more than 1%. And we can summarize, as better the adherence to treatment, as lower the risk for experience of esophageal food infections. We cannot eliminate it 100%, but we can dramatically reduce this risk. Summarized, EoE is a chronic disease with almost obligatory relapse after cessation of any anti-inflammatory treatment. Relapses harbor several risks, for instance, injury of the esophagus, aspiration pneumonia, or remodeling with development of structural damage of the esophagus. Food infections can be prevented by appropriate treatment, and in order to prevent relapses, a consequent diagnostic and therapeutic long-term management is required. The next question, which drug and which dosage is sufficient to maintain EoE in remission? First, few comments to the drug. For swallowed topical corticosteroids, we have 2 long-term, concrete 1-year studies. For biologics, in particular, RPC 4046, an IL-13 blocker, and for dupilumab and combined IL-4, IL-13 blocker, we have data from open label extension studies. But biologics are currently not available in the routine. They are reserved for using under study conditions. And for PPI, we have currently no data regarding the efficacy as prevention of the relapses over a long time period. I therefore will exclusively discuss the topical corticosteroids. These are the results of a single center study published in 2011. We used budesonide 0.5 milligram per day as maintenance treatment. And here you can see the data of the right now in gastro published Pool 2 study. We have 2 treatment dosages, a 2 milligram per day and a 1 milligram per day dose of budesonide. And if we compare, if you summarize these results, the median time to relapse with 0.5 was 125, with 1 milligram 350, and with 2 milligram 354 days. We can conclude the relapse rates under budesonide 1.0 and 2.0 are not significantly different, whereas the relapse rate under 0.5 milligram is markedly higher. Side effects, candida, adrenal suppression of the different dosage are not different. Currently, despite limited data, a daily dose of 1.0 milligram budesonide per day can be recommended as standard dose for long-term treatment. Another practical questions, how long should we treat? Facts, EoE is a young disease. We are aware since the early 90s, but our knowledge regarding long-term evolution of the disease and long-term risks of the disease are still limited. We have no idea how long in a given patient EoE will remain active. And in my clinics, I know patients, their EoE burns out, is not anymore active, and in other patients, permanent and anti-inflammatory treatment is needed. EoE is not simply EoE. We have different clinical courses. Therefore, I recommend today that we use a 1-year strategy. We treat for 1 year under stable condition, and after 1 year, we reconsider clinically and endoscopically, and we show if the treatment is still necessary or not, if the patient is still motivated for treatment or not, and then we plan another year if necessary. Finally, how often should we see our patients? Facts, we have no data. And this is a pure anecdotic recommendation, not evidence-based, but based on the dentist's practice. I propose under stable conditions a 1-year perspective in order to keep patient-physician connection active, in order to maintain the adherence to treatment, and in order to search for disease and treatment-related complications. For instance, systemic steroid side effects, and so on. Here, briefly, an algorithm published in Allergy last year. After induction treatment with topical corticosteroids or double-dose PPI or elimination diet, we have to evaluate this 2 to 3 months later. And if the patient is a responder, we switch to maintenance treatment with a lower dose of corticosteroids. If the patient is a non-responder, we have to distinguish, is the inflammation non-responding? Is the inflammation still active? Then we have to change, to modify our anti-inflammatory treatment. If the inflammation is under control, histologically less than 5 eosinophils, then likely the remodeling is responsible for his symptoms and we dilate gentle. Anyway, after achieving a clinical and histological remission, we have to switch to maintenance treatment, even after dilation, because dilation does not suppress the underlying inflammation. This is, and for definitely non-responder, please consider biologics. For instance, dupilumab or RPC 4046. Thank you for your attention, and I'm sure you have questions.
Danke, Alex.
Jetzt hat das Telefon reingefunkt.
Das ist nicht so schlimm.
Nicht schlimm.